Hi guys, this is Alex from Salmonella Place, and right now I'm going to give you a lecture on antidepressants. So, depression, otherwise known as an affective disorder, occurs when there is a change in mood. So you either have depression or you have mania. Now, the emotional symptoms that are seen when somebody has one of these two mood swings is misery, apathy, pessimism, guilt, and lack of motivation. Meanwhile, the biological symptoms include retarded actions, decreased libido, lack of appetite, and sleep disturbance. Now I'm going to categorize or classify depression. So the first type is reactive depression. This is the most common type, and it is the response to a stimulus, for example, death or an illness, drugs, or toxins. It's non-familiar, so it is not inherited, and it is made up of core depression syndrome, which includes depression, anxiety, guilt, somatic pain, among other symptoms. Then you have endogenous depression, which is linked to a genetic background. It's a genetic biochemical disorder, and it is familiar, so it can be inherited. Apart from what I mentioned previously, which are the symptoms in core depression syndrome, you can see sleep disturbance, decreased motor activity, decreased libido, and lack of appetite. And the third type of depression is bipolar disorder. This is when the person can have depression and mania. It's usually seen in early adulthood, and it can be inherited. Now I'm going to go through a bit of the history of depression. So the pathogenesis of endogenous depression. This started off with the monoamine hypothesis, which basically says that reserpine inhibits the storage of amine transmitters, serotonin and noradrenaline, and that causes depression. Now, there are theories that support this and theories that disprove it. Here are some of the evidence that supports this theory. Tricyclic antidepressants inhibit noradrenaline and serotonin reuptake, and they also MAO inhibitors increase the stores of these transmitters in the central nervous system. Now, this is normal. Now, alpha-methyl-DOPA or alpha-methyltyrosine inhibit noradrenaline synthesis. This causes depression. And as I mentioned before, reserpine also depletes noradrenaline and serotonin, causing depression. So all of these things prove the monoamine hypothesis. However, this evidence disproves the theory. The fact that amphetamine increases noradrenaline release and inhibits its reuptake. However, there is no antidepressant effect. The same is with cocaine when it inhibits uptake 1. Also, with 5-oxytryptophan, it increases the synthesis of serotonin, but there's no effect. L-DOPA also increases noradrenaline synthesis, and again, no antidepressant effect. Iprindole has no effect on monoamine metabolism, but it does increase mood. So this is completely the opposite to the monoamine theory. And finally, antidepressants immediately increase amine metabolism, but it takes weeks to have effect on mood or mood stabilization. Having taken these into consideration, the latest antidepressant theory explains that the inhibition of noradrenaline and serotonin, the neurotransmitters, and their uptake increases the number of transmitters that can activate the receptors in the presynaptic cleft. Now, if we inhibit the neurotransmitter release, but there is no change in the concentration in the cleft, and repeatedly administer antidepressants so that there is a decrease in autoreceptors through tolerance as the weeks go on, there will be an even larger increase in the level of transmitters in the cleft, and there will be an antidepressant effect. So this is the latest theory. Now I'm going to go on to the drug groups. So let's talk about tricyclic antidepressants in the first generation. Okay, so they inhibit noradrenaline and serotonin reuptake by monoaminergic nerve terminals, and they increase the monoaminergic transmission. The drugs that are used are imipramine and amitriptyline. Their side effects, firstly in the CNS, include sedation, drowsiness, and then there is dry mouth, blurred vision, constipation, urinary retention, tachycardia, postural hypertension, and the alpha-1 block in the vasomotor center. Acute overdose can give the side effects confusion, mania, and cardiac dysrhythmia. They are first metabolized and converted to secondary amines, and then they are converted by the CYP450 enzyme in the liver. They interact by plasma protein binding. They also compete to bind with aspirin. They should not be mixed with alcohol, as this can cause severe cardiovascular and respiratory depression, and they are not given with MAO inhibitors. Okay, now let's go on to the selective serotonin reuptake inhibitors, or SSRIs. Their mode of action is to inhibit serotonin reuptake, and the results are visible after 2 to 4 weeks. They have good absorption within 15 to 24 hours. Fluoxetine is the main SSRI drug. Its side effects include nausea, insomnia, sexual dysfunction. They also inhibit CYP450. However, the drug interactions are quite serious. If you apply MAO inhibitors with SSRIs, you get serotonin syndrome, which causes restlessness, tremor, hypothermia, hyperreflexia, cardiovascular collapse, and coma. They are used in depression, anxiety, panic attacks, OCD, PTSD. I'm just going to say OCD is obsessive compulsive disorder, and PTSD is post-traumatic distress syndrome or post-traumatic stress disorder, chronic pain, and psychotic disorders. Now on to the MAO inhibitors. Now, let me just explain a little bit about MAO, or monoamine oxidase. There are 2 subtypes, A and B. A is the main drug target of MAO inhibitors because they prefer to target serotonin, and MAO-B is selectively inhibited by selegiline because it prefers phenylethylamine. The drugs that are used in this category are phenelzine, tranylcypromazine, iproniazid, and modobemide. Quite a mouthful there. These are non-selective, irreversible MAO inhibitors, so they are not selective between MAO and A and MAO-B. They will inhibit both, and they're irreversible, so they don't detach from the monoamine oxidase once they've attached. Their mode of action includes intracellular inhibition of amine degradation and increase in the synthesis and release of these transmitters by in increasing the presynthesis stores. Their side effects include hypertension, increased central nervous system stimulation, which causes tremor, insomnia, and excitement. However, in overdose, it can cause convulsions, weight gain, atropine-like effects, and hepatotoxicity. The interactions include the cheese reaction, which is when MAO inhibitors are given with tyramine, and there are high amounts of tyramine in wine and cheese, and this can cause severe hypertension. And serotonin syndrome, like I mentioned previously, when MAO inhibitors are mixed with SSRIs. Finally, I'm going to tell you about the last drug group, which is lithium. It's a mood stabilizer. It's used for prophylaxis in bipolar disorder. It inhibits both phases. However, in an acute attack, it only inhibits mania. Its mode of action is that it mimics the sodium in excitable tissues, and it's not pumped out by the sodium potassium ATPase, so it accumulates in the cells. It also inhibits the synthesis of IP3, DAG, and cyclic AMP. The drug that is used is lithium carbonate. It's given orally, and it has a half-life of 20 hours. The side effects include nausea, thirst, polyuria, hypothyroidism, tremor, weakness, mental confusion, dysrhythmias, and it is enhanced by diuretics. So guys, that's the end of the antidepressants. If you have any questions or comments, please leave them below this video. If you'd like to see more pharmacology lectures or other medical lectures, please visit salmonellaplace.com or any of the links below. Thank you.